Well, I think CAR T therapy has activity. We know that. Perhaps hasn't looked as good as in lymphoma or ALL. And I think part of that is because, of course, you have to remember that with CAR T therapy, you are taking the patient's own T cells and redirecting them to the leukemia. And patients with CLL tend to have exhausted T cells, and they don't function very normally. So I think that's part of the reason the data hasn't been quite as good in CLL. On the other hand, we do think that some of that quote-unquote T cell exhaustion is also from the effects of chemotherapy. And so as we move away from so much chemotherapy and more to the small molecules, it'd be possible that some of the T cell function will be better. On the other hand, my own impression is that because we have all these active agents, and chemo is very active too, that until we can get the toxicity profile really lowered in terms of the CAR T, that it's going to stay the way it is now, which is sort of a last resort, because of the toxicity. I mean, if you look at all comers, about 25% of patients who get a CAR T wind up in the ICU. So again, that level of toxicity may be offset by some great efficacy, but when we have many other drugs that we can use before the CAR T, I think that still is remaining sort of a third or fourth or option in CLL. But it's certainly possible that if further ongoing research with the CAR Ts finds ways to really reduce the toxicity profile in terms of the cytokine release and the neurotoxicity, then we may see it moved up in terms of the sequencing.